Well, it is almost, or now it's 9 o'clock. So I'm gonna give the floor to Samantha to introduce you.
Great.
Yes. So good morning, everyone. Thanks for coming again and welcome to Dr. Silverstein. And thank you for taking the time to talk to us this morning. So I'm just going to give you a little brief intro and then the floor is all yours. So Dr. Silverstein is a supervising clinical neurophysiologist in the Department of Neurology at Northwell Health and a clinical assistant professor of neurology at Zucker School of Medicine at Hofstra/Northwell. Throughout his career, he has authored many peer-reviewed manuscripts. These publications reflect Dr. Silverstein's dedication to advancing the field of clinical neurophysiology. In addition to his research efforts, he has actively mentored medical students from the Zucker School of Medicine, as well as neurosurgery, orthopedic, and ENT residents, along with clinical fellows at Northwell Health. So without further ado, Dr. Silverstein.
Thank you. I thought you were going to read the entire bio. Hello, everyone. Welcome to Brain Turns. Thank you, Brain Turns and Lennox Neurosurgery, for inviting me. I think this is my third or fourth year lecturing in neuromonitoring. And I'm not going to go into the kind of history of neuromonitoring here, or even some of the weeds of neuromonitoring. So if anybody's interested in learning about that, feel free to go to the Brain Turns YouTube, because I did give an introduction of clinical and surgical neurophysiology a few years ago. We're going to kind of focus on case studies. So, but first, I will give you a little bit of background on what neuromonitoring is, or neurophysiological monitoring. It's a specific discipline that focuses on monitoring the nervous system of patients who are undergoing surgery, and specifically surgeries where their nervous system is at risk. So whether it's cranial surgery or spine surgery, I'm involved in cardiac surgeries, peripheral nerve surgery, different type of orthopedic surgeries, depending on if there's nervous structures at risk. And there are two components of neuromonitoring that we do. One is actually monitoring the patient's nervous system. My job is to basically move for the patient while they're under anesthesia. Since they're not awake, they can't move. So we have to make sure that they are able to move. And I'm able to give the surgeons feedback to the status of their nervous system while they're under general anesthesia, while the patient's under general anesthesia. The other component of neuromonitoring is mapping and finding neural structures. Sometimes the anatomy gets skewed. It's disrupted or disoriented due to maybe a tumor or scar tissue. And by electrifying tissue, we can differentiate nervous tissue versus non-nervous tissue. And that's the two components of the job. One component is actually monitoring the function of nervous system, and then the other component is helping identify nervous system structures during surgery. So we're going to kind of talk about this is really going to focus on the monitoring side of things. This lecture specifically. I don't have anything to disclose. I'm not conflicted. So really, from a really basic standpoint, what is neuromonitoring? So neuromonitoring is the stimulation and recording of the nervous system. And we do that by placing electrodes in all different areas of the body. So for example, if I want to record a muscle um, activation, I place needle electrodes in different muscles that I want to target, depending on if there's nerve roots or the spinal cord's at risk, and I want to see how that muscle is functioning. Um, that's one component, it's a motor test. Then we have sensory tests where we stimulate over sensory nerves in the peripherals, arms and legs, for example, and we place recording electrodes over the brain and we record basically those action potentials as they travel through the spinal cord to the brain. So the idea is the nervous system acts like a highway. And if there is a traffic jam along that highway, the testing that I'm doing will see that and I can intervene. The idea behind surgical neurophysiology is to be able to predict and prevent um, neurological damage. We want the patients waking up at least how they came in to the surgery. And you have to understand, the patients that we see It's complex because they've already have damaged nervous systems. So the idea is that if they come in with a deficit, we don't want the deficit to be worse. They come in with no deficit, we don't want them waking up with a deficit. So the goal is to predict and prevent neurological damage. Sometimes we are there to predict damage, and that helps us in the post-op management course of helping the patient with rehab. But the true nature of surgical neurophysiology is to predict and prevent um, nervous system damage, as well as identify nervous tissue to ensure that it's not damaged during surgery. Okay. So we're gonna kind of go back and forth with some of the procedures that we're involved with. Between in this specific lecture, I'm going to discuss more spine or cranial surgeries. The first case that I want to discuss, it's a thoracic to lumbar fusion. This is a pretty standard case that we do all the time. This was a T12, so it's a lower thoracic to an L5, which is kind of your lower lumbar area. And the patient's an 83-year-old female with a slew of underlying medical problems. And that's important for us to understand. Part of my job, one of the biggest aspects of my job is to manage expectations. And what I mean by that is when I come in to test the nervous system, I'm running multiple tests during a procedure. I have to be able to give the surgeon actionable information. And the only way that I can do that is if I have an understanding of the patient's clinical history, what they're potentially going to give to me, and what's at risk during the procedure. So when a patient comes in with this type of medical history, we're already on high alert because all of these things, any kind of cardiac issue, blood pressure problems, anything that's going to cause problems to the nervous system, such as chronic renal failure, which can cause a uremic neuropathy. These are things that I have to take into account when I'm trying to test the patient, especially because these patients are going under general anesthesia. And the whole idea of anesthesia is to suppress the nervous system, right? They want to not have the patient move, not feel anything, keep them asleep, obviously, not remember anything. So all the medications used to keep a patient anesthetized suppresses the nervous system. My job is to excite the nervous system. So there's kind of a game we play to, kind of a dance that we do with our anesthesia colleagues to ensure that we're able to excite the nervous system, but the patient's still under enough anesthesia, they're not going to remember or feel anything. However, once you superimpose a slew of medical problems, it makes things that much more difficult. I comment here that the patient has edematous ankles. This is important because we're going to stimulate areas of the nervous system of the body. I'm sorry, of the body that could be affected by edema. For example, one of the nerves that we target to stimulate is the posterior tibial nerve, which is in your leg, and it's down at the ankle where we stimulate. So if you have edematous ankles, it's going to make it more difficult for us to get responses. So in a case like this, like I said, we do multiple tests during surgery. In this case, we're doing three different types of neuromonitoring tests. We're doing a somatosensory evoked potential, and we're doing spontaneous and triggered electromyography. So a somatosensory evoked potential is a sensory test that stimulates the peripheral nerve, and we put electrodes, basically microphones, on the scalp, and we record that terminal pathway of the sensory function. Very powerful information. We use it as a surrogate for motor, even though it's a sensory test. We use it as a surrogate for motor because a lot of neurological injuries that occur in surgery are due to perfusion issues, so a lack of blood to the nervous structures. So that's where the sensory tests become a surrogate for motors. These are what we call time-locked recordings where we're stimulating and recording, which means we can see if there's a conduction failure, there will be a stop, that highway, and we'll see that because the waveform that we're looking at a microscopic view of the nervous system on a computer, and we sit next to the anesthesiologist, and we're looking at a microscopic view of the nervous system on a computer screen, and we see these waveforms. And if the waveform changes, we know there's a problem. Now, other tests that we do include spontaneous testing. So that's sticking just a needle in a muscle and looking at muscle firing because a nerve gets irritated. That's spontaneous. We're not triggering anything. We're not stimulating anything. We're just looking at the body's natural reaction through their biological activity. And then triggered EMG is a time-locked stimulation where we stimulate a nerve and we record a muscle potential. So that is time-locked. And then we also do a test called motor evoked potentials where we stimulate the motor system and record motor signals from the patient. Now, in this specific surgery, the surgeon decided that they did not want motor evoked potential. So all we were doing were sensory tests and these nerve root tests. So what you're looking at here on your screen are the different nerves that we targeted in this case. The deep peroneal nerve is a nerve that is very important because it helps you dorsiflex your ankle. And if you lose function to dorsiflex, you'll have a foot drop. The posterior tibial nerve, on the other hand, is the nerve that helps you press the gas pedal down, your plantar flexors. So we run both these tests concurrently throughout the procedure to ensure that the nervous system is stable, especially when they're working in the lumbar spine. Now, what you're looking at is what I look at on the screen. These are waveforms here, and obviously I'm not going to get super specific with this, but you can see here's the waveform, and then all of a sudden it gets different. This is different. It's not the same, and this is where things started to go kind of wrong in this procedure. So what happened here was, so this is the left deep peroneal SSEP. And all of a sudden the SSEP starts getting very, very not stable. And this is the left side. The right side, as you can see, remains stable. And then these other nerves, because they're completely separate nerves, also remain stable. They don't change throughout the procedure. So the first thing that I think about when I see an isolated change like this is it surgically induced versus maybe a positioning problem. Now we're putting patients on an OR table, and they're in a fixed position. And think about your arm falling asleep when you're sleeping, and your hand gets numb, right? What do? You move, and all of a sudden your hand's not numb anymore. Well, that is the first phase of a conduction block of your nerve. Your nerve is falling asleep, basically, because it's losing blood supply because you're compressing it. So if you're under anesthesia, you can't move. I'm watching the nervous system so I can actually move for the patient. So when I see a deep peroneal change, the deep peroneal nerve is actually very superficial as it crosses by the knee. And I'm going to show you a picture of that. So what we worry about is some of the straps that we hold the patients on the table, maybe compressing the nerve. So the first thing that we do is we evaluate the leg to make sure there's no positioning problem. Once we do that and we see that everything is fine, next thing is this a surgically induced trauma? So sometimes, especially in spine surgery, you can't really see what the surgeons are doing all the time. And so I have to ask them, hey, what did you just do? And in this situation, I did. I said, what did you just do? Oh, we just put a screw in at L4 on the left. I said, okay. So now we're starting to put the pieces together. Screw went into the L4 vertebral body pedicle on the left side, and I have this change of signal. So I tell the surgeon, look, there's a change to the deep peroneal SSEP. This could be indicative of some kind of trauma to the nerve. And they said, okay, we're going to look at it, but we're going to take X-rays soon, and we'll stimulate the screws. And the way that we stimulate screws is we can actually electrify. So this is a pedicle screw. This is the pedicle here. This is the screw going into the vertebral body. Here's the nerve. When we can take a probe and actually electrify this screw. And the idea is that by electrifying the screw, we can have an idea of the distance to nervous tissue it is based on how much current's needed to elicit a response from the muscle. So, for example, the higher the intensity needed, the more encased in bone we are. Because if you're next to nervous tissue, it should activate at a much lower threshold. That being said, the literature says that if you're below 10 milliamps of current, it's indicative of needing to evaluate that screw because there could be a potential breach. When we talk about breaches, we talk about medial breaches, so breaches that go this way, going towards the spinal cord or the nerve itself as it comes off the spinal cord, or inferior breaches that go down this way into the foramen that compresses the nerve as it comes out and exits the spine. Now, these numbers here that I'm showing you are the pedicle screw values in milliamperes from this case. So we have this change to the perineal nerve, and all of these screw values technically are good if we just went strictly by the literature, because everything's above 10 milliamps. However, we're trained to look for outliers. And again, talking about those chronic conditions, it might, a patient with underlying comorbidities might need more stimulus intensity to activate nervous tissue. So if you notice, the left L4 is 18 milliamps compared to all these other screw values, which are in the either the 50s or the mid 30s. That right there is kind of a red flag for us. But then you say, well, Dr. Silverstein, what about the right L3? That's also kind of an outlier. I'm going to talk about that in a second because it is true, and there are false positives that occur in this. It's not exact science, unfortunately. But basically, the left L4 really caused us to pause between that and the loss of signal here. The surgeons found that they had inferiorly bleached. They took an X-ray and they found that they inferiorly bleached the pedicle. So the screw was sitting on the nerve, compressing the nerve, which caused a conduction block, which caused this to happen. They took the screw out. As soon as they took the screw out, within a few minutes, we started to get a signal back. As you can see here, the signal comes back, and this patient ended up being okay. If we didn't intervene, the potential deficit this patient would have woken up with was most likely a foot drop. Devastating injury. So now let's talk about this right L3 screw. The surgeon actually pulled me aside and said, hey, Justin, you know all our tricks. Basically, they knew that they had breached going in medially when they first passed the screw, and they automatically took it out and redirected it. But they already created that hole. There was a hole here now. So when we stimulated, we put electrical current through the screw. Current is supposed to go down the screw through the body, but because there was a hole now in the pedicle wall, you had the shunting of current onto the nerve, causing a lower threshold for that nerve. So that's what happened here. It was a good save. This patient woke up intact and with a great outcome. This is just showing you some of the anatomy. The perineal nerve is 3 nerves. It travels along with the posterior tibial nerve as a sciatic nerve, coming off the sacral plexus down the back of your thigh. Right above the knee, the back of the knee, it splits off. The posterior tibial nerve continues straight, and then the common perineal nerve kind of starts deviating laterally on a short segment across the back of your knee. And then as it crosses the fibular neck here, it splits into 2 other nerves, your deep perineal and your superficial perineal. Now, your deep perineal nerve is what controls or what activates dorsiflexors. Your superficial perineal activates your foot inverters. We focus in spine surgery on the deep perineal, but you really want to focus on the dorsiflexors. We will focus on all three if I'm doing a peripheral nerve surgery, such as a perineal nerve surgery itself, but this is the anatomy and this is what we're looking at and why we're looking at it. And so what happened was, instead of a medial breach, there was this inferior breach compressing the nerve within the foramen, the vertebral foramen here. So now we're going to switch over to a cranial procedure. We work in a lot of cerebrovascular surgery, and this is a case study of an unruptured right middle cerebral artery aneurysm. You can see it here. It's a nice big complex aneurysm. Now, we're in the age of what's known as the endovascular error of aneurysm treatments, where they try to do all aneurysms endovascularly in the interventional radiology suite by using coils or flow diverters. However, we come to the operating room and do open craniotomies for aneurysms when they're big, they're complex. So we're not seeing small little aneurysms. So we're seeing the more complex, the more dangerous aneurysm. Here is a 65-year-old female, no relevant surgical or medical history, and they have this unruptured aneurysm that we're going to place a clip across, and we do a pterional craniotomy under general anesthesia, and then the modalities that we do in this surgery, and like I said, we do multiple tests during the procedures, but every surgery has tests tailored to that surgery and has target structures that are tailored for that surgery. So in this case, we do transcranial motor evoked potentials, where we stimulate the motor cortex through the cranium. So transcranially, we send upwards of 1,000 volts through the cranium in order to get muscle potentials from needles that we've placed in various muscles in the body. We also do direct cortical motor evoked potentials in a case like this, where once the craniotomy is performed, we slide a grid electrode on the brain, and I'm able to stimulate continuously the motor cortex. And we do these two different types of motor tests for a reason. They both give us very powerful information, but there's also limitations to these tests, and they kind of counterbalance each other, which is why we do two different tests. We're also going to do the somatosensory evoked potential, as I discussed, and then we also do a spontaneous EEG in a case like this. So for our purpose, it's important to understand what we're doing in these cases and why we're there. And one of the most important reasons why we're there is for temporary parent vessel occlusion. So one of the reasons why we have to stop the blood flow to the aneurysm in the surgery, so it doesn't rupture when they place the permanent clip on. And one of the ways that we do this is by doing a temporary vessel occlusion. Now, you're talking about the parent vessel. So, for example, in this case, we're going to occlude the middle cerebral artery. Now, the idea is that when you occlude the middle cerebral artery, you should have collateral flow from the other side of your brain and from other vessels to make sure that you don't have an ischemic event and lose motor function. That's why I'm there. I can actually tell in real time when the patient's having an ischemic event, and we can reverse that. And this is just showing you what temporary clipping looks like. Here's the temporary clips here, and then a permanent clip going over the dome of the aneurysm. So what we're looking at here is what on my screen looks like. This is my transcranial motor evoked potential baseline. These are the responses here from our arms down to our legs. And then here are direct cortical motors. Remember, these are motor potentials that are activated by stimulating through the cranium. And then these are motor potentials that are activated through a strip electrode or a grid electrode that's placed directly on the brain as it's open. And you can see they look fairly similar. And we have a good baseline. And it's super important. But what you'll notice now, on direct cortical motors, we need much less current because we're right on the motor cortex. So it's a very, very localized stimulation, and there's no movement associated with it. So we can run it with impunity. Whereas transcranial motors, one of the limitations to it is that it causes patient movement. We have to give that much more voltage in order to penetrate the skull and the tissue. And the issue that we face is that we don't know sometimes if we're stimulating too deep in structures that are at risk, especially in brain surgery. Spine surgery, this isn't really a concern for us. This actually is not a concern for us at all. In brain surgery, though, if we're worried about the cortex, then we could potentially be bypassing the cortex with transcranial motors because we don't know how much current that we're using is penetrating, how deep it's penetrating. One of the ways that we try to mitigate this is, if you notice, I have an ipsilateral hand. Remember, the right side of the brain controls the left side of the body and vice versa. So this is a right-sided craniotomy. These are left muscles that are activated. But if you notice, I have an ipsilateral hand. And the reason for that is we're looking for what we call the crossover response. Now, the crossover response is a response that tells us that we're definitely penetrating too deeply. It just means that we're activating subcortical structures and we're activating both sides of the body at once. And this is no good because we're definitely in a craniotomy bypassing structures that we want to monitor. So one of the ways that we can mitigate potentially bypassing structures at risk is for controlling for the crossover. So what happens is we end up getting this crossover, and then we reduce our stimulus intensity to the point where the crossover goes away. And we hope at this point that we're still not bypassing structures at risk, but this definitely reduces the chance of that happening, but it's not infallible. It still happens, and that's why direct cortical motors are that much more are that much better in these situations. So this is a trend over time from top to bottom, beginning of the case and the end of the case, and you're looking at different muscles, and these are the motor responses. These kind of dark patches here. These are the motor responses. And what you'll notice in this case, and guys, everything that I'm discussing, we've published on, whether it's been in a case study or in a series. So there'll be links to some of my socials and my PubMed at the end of this. So feel free to check it out, or you can just email me. I'll be more happy to send you any of our papers. We do a lot of research in this space just to make surgery better. That's the idea. So here, what you see here is when the temporary clip goes on, the upper extremity from our direct cortical, these are all our direct cortical motors, they start to go away. And you can see it here, they're completely flattened. This is okay. This is a controlled ischemia. We know that we have time where it's reversible. So as soon as this happens, we alert the surgeon. The surgeon then removes the temporary clips to reperfuse the brain. And then what you see here is the responses return. Now notice the lower extremities never change. And that's because this is the middle cerebral artery that's being occluded. So the middle cerebral artery is what perfuses the part of your brain that controls your face and your arms, not your legs. Those are different vessels. So that's why the legs don't change here. And this is important. These end up being control groups for us. So we know this is real. We know that there's an event occurring. So we alert the surgeon. We have a loss of signal, of motor signal here. They take the temporary clip off, and we get perfusion back. Muscle responses come back. So how this works is temporary clip comes off, we wait, there's some surgical pause, and as the responses come back, then we proceed with the procedure. Responses come back, temporary clips go back on, and within a few minutes, we lose signals again. The surgeon then expedites the permanent clipping, puts the permanent clip on, removes the temporary clip, and as you can see, as soon as they remove temporary clip, the responses come back. So this, again, was a situation where the patient woke up completely intact neurologically. That's important. If we weren't there, potentially, the surgeon wouldn't have known that the patient became ischemic, and they could have woken up hemiplegic. Now, there are techniques that surgeons employ when we're not there in these cases that they try to mitigate cerebral ischemia, such as like what they call the on-off method, where they will do temporary clipping for 3 minutes and then automatically take it off for another 5 minutes, wait, temporary clip for another 3 minutes. So there's a constant kind of give and take throughout the procedure. By employing neuromonitoring tests, we don't have to do that. We can keep the clip on as long as necessary in order, as long as there's no conduction failure of the nervous system. But as soon as the first sign of conduction failure occurs, we intervene and reverse it. And we end up with great outcomes doing that. So this is that same case. Now, this is the transcranial data looking at from top to bottom, trend over time from the beginning of the case to the end of the case. So what I've circled here, these are and you can tell the motor potential, the transcranial motor potentials, there's not as many as direct cortical motor potentials because we can't run them as often because of patient movement. Now, what you'll see here is what I've circled is the point of temporary clipping. And though we've controlled for this crossover, when we've lost the signals from the direct cortical motor potential, we never lost the signals here from the transcranial. So if we weren't running two different motor tests in this case, we could have potentially had an issue where what this would be called a false negative, where the motor test never changed, but the patient potentially would have woken up with a devastating paralysis, because what this is telling me is that we were stimulating past the damaged areas. And when you stimulate past a damaged area, you still activate those nervous tissues distal to a point of conduction failure, because it takes upwards of 48 to 72 hours before the nervous system starts not working distally. So in an acute injury, as we see in surgery, acute traumas, this is still active, hence there's no change here. So luckily we were running that direct cortical motor because we were able to intervene and the patient woke up intact. Now let's go back to spine surgery. We'll talk about C5 palsies. This is a well-known, poorly understood complication of cervical spine surgery. There's basically two different ways that we approach cervical spine surgery. Either you go through the front of your neck or you go through the back of your neck. A C5 palsy can occur with either approach. However, it might be more prone to posterior approaches, and there are two different types of C5 palsies that we see. There's an acute C5 palsy that we see intraoperatively, and that's the one that I can monitor and I can relay information to the surgeon about. And then there's a delayed C5 palsy, and what that is a palsy that occurs at some point in the postoperative phase. So the patient's actually neurologically intact about the procedure, and then after surgery, due to swelling or a reperfusion injury for whatever reason, they end up with a C5 palsy that occurs within hours or sometimes days later. And we can't detect that at all. We can't do anything about that. So our focus is acute, intraoperative, in situ injuries. So the reason why C5 itself is so at risk is that the anatomy of the nerve itself is different than all the other nerves in the cervical spine. It's a shorter, it's a more obtuse angle, so it's more prone to tension and being tractioned, which causes the damage. And so you don't really hear about like C3 palsies or C7 palsies really, but C5 palsies is definitely an issue. And again, it's because of the anatomy of the C5 root itself. It's just a different nerve compared to everything else in the spine. Again, like I said, it's shorter, its angle is more horizontal, so it's more prone, unfortunately, to injury and more vulnerable to injury. So here we're doing a C3 to 7, so cervical spine, anterior cervical discectomy infusion, where they're going to take the disc out and they're going to put interbodies into the cervical spine and going through the front. This is a 59-year-old male. Now they have myelopathy. Myelopathy is signal changes within the spinal cord causing weakness and other neurological problems. They have severe stenosis. And so this is their motor exam. And again, this is all the stuff that I have to understand when I'm testing a patient's motor function, especially when they're under anesthesia, is what kind of data am I going to get at least at a baseline. So as you can see, they're coming in with a strong left-sided motor exam. There's no issues. And then they have a little bit of weakness in the right side. So we come in, these are the tests that we're doing. So we're going to do SSCPs. We're going to do EMG and transcranial motor potentials. In spine surgery, we don't do direct cortical motors because we don't have access to the brain. We're not doing a craniotomy, so there's no access to the brain. So we're doing transcranial motor potentials. Now, I'm not worried about bypassing structures at risk here because I can't ever penetrate past the spinal cord with our stimulation. It doesn't go that high. So I'm not worried about that at all. And these are the muscles that we're targeting for our motor potentials here. So these are a bunch of muscles in the arms, and then we have lower extremity muscles that we also target because we're not just monitoring nerve roots, we're monitoring spinal cord function as well. And if the spinal cord is damaged or injured, we'll see changes potentially in the lower extremities as well. So it's important. We do, like I said, we do a lot of multitasking in these procedures. I'm watching the screen with multiple tests running at once and all different things happening. And when things change, I have to make split-second decisions on what's happening to that patient, and then give actionable information to the surgeon so they can intervene at some level. So again, trend over time. These are the muscles. All these kind of squiggly lines, that's the motor data. And what you'll see here is at some point where the black arrows are, the anterior deltoid and the biceps drop. And the middle deltoid and the posterior deltoid don't, which is interesting. And this was happening when they were putting a cage in or implant into the anterior cervical spine. So as soon as we saw this, we told the surgeon, this is very specific. And what happened was they tractioned the nerve because they put the cage they were putting in was a little too big. So they took the cage out and they put a smaller cage in, which released tension on the vertebral bodies. Because in order to get the cage in, they have to jack the vertebral bodies open. And once they took the cage out, the response from the biceps starts to come back in, but not the baseline. And the deltoid stays pretty much completely out anteriorly. However, because the biceps came back and the middle and posterior deltoids didn't change, we knew that this is probably going to be, if there was any type of deficit, it was probably going to be a transient deficit, which means it'll recover. Here's the other side showing completely stable signals throughout, no changes at all. And immediately post-op, the patient woke up with a partial left-sided C5 palsy. So 2 out of 5 in the left deltoids, 3+ out of 5 in the biceps. Remember, it was 5 out of 5 going in. So unfortunately, they did wake up with a palsy, which is still devastating no matter how you slice it. You know, you don't want your patient waking up with a deficit, but our immediate intervention led to this patient being completely fine within 7 weeks. If we did not intervene or we weren't there, for example, this may have been a 0 out of 5 and may not have recovered over time. You know, so it's important. It's the reason why we're there. Let's go back to the brain, and let's talk about supplementary motor area syndrome. So the SMA, supplementary motor area, it lives right in front of our motor cortex. So if we look at the brain, it's in the frontal lobe, it's in the posterior aspect of the frontal lobe. This kind of lighter blue is our primary motor cortex, and then right in front, kind of in the medial portion, is a supplementary motor area. Now, where primary motor cortex is involved with the cortical spinal tracts and, you know, direct motor function, the SMA is involved in the initiation and coordination of internal and external cued movements. So if you disrupt the supplementary motor area, then patients usually wake up with a transient hemiplegia and sometimes a transient akinetic mutism. And this is known as SMA syndrome. This is a well-known, well-documented syndrome. The problem is when we're doing brain surgery, is when the patient wakes up completely paralyzed on one side of their body, the question becomes, is this SMA syndrome or is the cortical spinal tract disrupted? And if the cortical spinal tract is disrupted, that means they're not going to recover. If the supplementary motor area is disrupted, they will recover over time. It takes a little bit of time. And that's where we come into play. We can't monitor specifically for supplementary motor area because it's not direct motor function. However, if we have motor function, direct motor function, we know that we can say with with confidence at the end of a procedure, as long as nothing's changed and the patient wakes up hemiplegic, unless something happened postoperatively, the patient will get better. So this was actually a cool case that we did. I did this with Dr. D'Amico a few years ago now, and this was the first time that we actually saw SMA syndrome in real time with motor potential. So we did publish this. So this is a craniotomy for a large parasagittal meningioma, and you can see this is a huge, huge tumor. And this is a meningioma, so it's not in the brain; it's on the brain. It's coming from the dura mater and it's pushing on the brain. So this is a 45-year-old male with well-controlled diabetes, hypertension, and HIV. And they came to the ER with a seizure caused by this tumor. So the plan was to stage this this craniotomy, do a right craniotomy and then a left craniotomy. So that was the plan. So do one day do the right craniotomy, and then come back a few days later and do the left craniotomy. So here's stage one. And what we're looking at here is the motor potential, a baseline, and then the post-resection potential. And what you can see is there's no change here. They're all the muscles that we're targeting, both direct cortical and transcranial, are intact and completely stable. So no change at all. Now, this patient woke up completely paralyzed on the left side of their body. And we said, well, this is most likely SMA syndrome. But at this time, we didn't have a lot of research. You know, we've actually published the largest series a few years later in this space. But at this time, we didn't really have a lot of data regarding SMA syndrome and motor neuron potential. So we were saying, well, we believe that the patient should be okay. And they started within 24 hours actually getting better. But then they ended up with a very specific deficit, a foot drop, which is very, very rare for a foot drop to be have an isolated foot drop from an SMA syndrome. And it's almost like a laser shot, and it's very, very rare, and actually it's unheard of. So we weren't sure, did something happen during positioning, and then as things started getting better from the SMA syndrome, we started seeing this deficit that might be more prolonged. So when we came back in a few days later to do the left side, we did the left craniotomy, and what we did was I targeted more of those dorsiflexor muscles to see, is there damage to the actual peripheral nerve, the perineal nerve. We spoke about perineal nerve earlier in spine surgery. This is now in brain surgery. But did we have that positioning issue that I discussed? And then, you know, did we have a peripheral problem that would need to be managed postoperatively? But what our data showed us was that the dorsiflexor, so our tibialis anterior muscle and our tensionalis longus muscles, completely intact, completely fine, which told us the cortical spinal tract is intact, specifically to the dorsiflexors. This is definitely an SMA, a very rare SMA presentation, SMA syndrome presentation, but it's definitely an SMA syndrome. And within a few weeks, the patient was completely fine. So again, a great outcome, and it really opened up our eyes to how we can utilize motor neuron potential from a prognostic standpoint to say, no, the patient will get better over time. Another procedure that we're involved in are trans-psoas approaches to the lumbar spine. Now, these are very, very risky procedures for spine surgeons because you have to go through this psoas muscle here. And what lives within the psoas muscle is the lumbar plexus. And the lumbar plexus is basically all of the nerves of your upper leg are originating here. And this includes a nerve that controls your ability to extend your knee, your femoral nerve. It's a very, very important nerve. And these surgeries, if you damage the femoral nerve, I mean, it is devastating injury. Patients can't walk. And even if it recovers, their swing gait is completely off. And it's unacceptable injury. So when they first started doing these, they were having upwards of 60% of these injuries. Myself and my group developed the techniques to actually monitor these nerves before this. Nobody's actually monitoring the specific nerves that are at risk there. So we developed the techniques and we reduced femoral nerve injuries to less than 1% by doing this. But this is basically what's showing a quadriceps palsy. This is 18 months post-op. You see the atrophy is devastating injury. And what's happening is the nerve is being crushed by the retractor that's going in. So this is a tubular retractor that goes into, laterally into the lumbar spine. And when it's opened up to work, it can compress or stretch the femoral nerve. And orthopedic spine and neurospine surgeons, they weren't used to these injuries. These are devastating lumbar plexopathies or femoral neuropathies, a lot different than a radicular injury. Because a radicular injury, they tend to get better. They're also not as bad because you have other contributing nerve roots to a nerve, where when you take out the nerve completely, you have no more contributing fibers. So I'm going to show you that here. So we developed techniques, the saphenous somatosensory evoked potential, which is a femoral nerve evoked potential, and then motor potential specifically targeting quadriceps muscles. And this is kind of a schematic of what we're doing here. So when I talk about transcranial stimulation, we put these corkscrew electrodes on the scalp. We screw them into the scalp with needles, and we screw them in, and we deliver current into the cranium, and we elicit the cortical spinal tract, and then it goes through the spinal cord, down through the nerve roots, through the peripheral nerve to the muscle. So if there's any kind of injury to the nerve, again, there's no back to lateral stimulation. So here we're stimulating, we're priming the alpha motor neuron, and then we get a response on our screen. That's what it looks like. But if you have an injury to the nerve itself, you've taken out your collateral. There's no more nerve root. Again, why this is not a radicular injury. Radicular means coming from the nerve root versus a nerve injury. And there's no place for the impulse to go. That's that traffic jam. That's that conduction block. That's that conduction failure. And this is easily, now this I'm showing you a very, very black and white version of this where we're transecting nerves. We're not transecting nerves in these cases. We're stretching the nerve or compressing the nerve, causing conduction failure. But it acts the same way, but removing the retraction usually mitigates this issue. It's the same idea as taking a temporary clips off. These are ischemic events. You're cutting off blood supply to this nervous tissue. So these are the modalities that we use in a lumbar lateral interbody fusion. We do a slew of testing. Muscles that we're targeting here. We're looking at a lot of different things. And these are two cases that show kind of the value in this. So the first case, you're looking at saphenous SSEP, and the quadricep motors are left and right. And highlighted in green, this is again trend from the beginning of the case to the end of the case. And you can see in green, these are nice, what we call stable signals from the left side. And then during at some point during surgical retraction, that's this kind of blade here that's compressing here, the femoral nerve. There's an axial slice of the L4-5 level. And basically when they open this retractor blade, it presses on this nerve, and you can have, it doesn't happen all the time, but you can have a signal chain. And if you have a signal chain, such as here, and you see the red, it completely flatlines. And then the same thing happens to the motor potential. Here's the motor potential, green, 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 yellow starts getting bad, and then red, it's all the way gone. This is at the point where we intervene and we say, okay, guys, we have a conduction failure. It's time to, release the retraction, potentially remove the retraction, or expedite the procedure. We know this is an ischemic event. We know we have some time, but we don't have all the time in the world. So once this happens, the clock is on, and we need to either reperfuse the tissue or and get out. So basically, we told the surgeon, they removed the retractors, and as you can see, the responses came back, and this patient woke up completely intact. Now, here was another procedure where we have the signals here, and then they start getting kind of wonky, and then completely flatline. And as you can see, they never recover here. And the same thing happens with the quadricep motors here. And you see it's very isolated. So again, we have our control muscles. These are distal leg muscles, different nerves that are being innervated. So they act as controls for us. They tell us that this is real, this is very specific, and where it's occurring. So you can see there's a complete flat line of the signal, and which never recovered. Now, in this situation, you have to understand, and this was done well over a decade ago before we really proved these techniques. And this was actually this surgery was completed by a research partner of mine out in the West Coast, and he alerted the surgeon to this change. But at the time, a lot of us and a lot of surgeons didn't really know what to do with that information. So they just kept on going with the procedure, unfortunately. And when the patient woke up, they had a complete 0 out of 5 knee extension. So a complete quadriceps palsy, a devastating, devastating injury. So what we've shown with 100% specificity and sensitivity is if we get to the point of a conduction failure, as long as we intervene pretty immediately, the patients all wake up completely fine. If there's no intervention, such as this case, all those patients will wake up with deficits, and they're devastating, devastating deficits. Let's go back to the brain. We're going to talk about a microvascular decompression for hemifacial spasm. Hemifacial spasm is basically the nerve in your face, the nerve that controls your face, is being damaged by a vessel that's pulsing on it, causing a twitch in the face. And so here's a 62-year-old female with a left-sided facial spasm for more than 20 years, a lot of left-sided facial muscle atrophy, left-sided muscle atrophy due to this consistent pulsing and pulling of the face, but they had no relevant surgical or medical history. So just to give you an idea, they access the cerebellopontine angle here, where this cranial nerve 7 is, the facial nerve. They go right behind the ear here, and when we access the facial nerve, which is your 7th cranial nerve, and your auditory nerve, which is your 8th cranial nerve, they kind of live together. They're very, very close, and but you want to identify the 7th nerve because that's the one that's controlling your ability to smile. And there's a vessel that's typically wrapped around it and compressing it. And the idea is to put kind of a sponge in between the vessel and the nerve, and that takes away the hemifacial spasm. So we are doing a few tests in this procedure. So this was one of our tests to identify the nerve. So what you're looking at here, so there's a nerve there. That's what the nerve looks like. This is what we call a cartouche stimulation dissector. So this is a surgical tool that the surgeon can use to either peel tumor away or manipulate vessels or nerves. But at the same time, I can electrify this and stimulate nervous tissue. So we put this on this nerve, which we think might be the facial nerve. And these are facial muscles. These are 4 different muscles in the face. And we're stimulating between 0.1 and 0.5 milliamps, and we're getting no responses from these muscles. So this is telling us this is not the facial nerve, or potentially the facial nerve is damaged. We know the facial nerve is not damaged, so this is most likely not the facial nerve. So at this point, I tell the surgeon, well, let's start wrapping the probe around the nerve and see if we can tease out the nerve. And as we start getting to the side, we get a response from one of the facial muscles at 0.5 milliamps. Again, this is a little high for stimulation, especially directly on the nerve. I'm telling you because again, we're not directly on the facial nerve, but we're getting closer as we come around the other side of this nerve that we're looking at. And then once we get to the back end, as you can see, we get all branches that we're targeting for facial muscles at a much lower intensity of 0.1 milliamps. So what's that telling us is that what you're looking at here is the 8th nerve, your auditory nerve, which is a sensory-only nerve. And on the other side of this, which you really can't see, is the facial nerve, which is what we wanted to find, which we found, and then the surgeon was able to dissect and find the offending vessel. So this is what it looks like when we place electrodes in different muscles in the face here. And these are the type of electrodes that we use for any type of monitoring that we're doing. So we'll put these electrodes in the arms, in the legs, for example. Now, in this specific case, we also, this blue and black electrode pair here and this red and black electrode pair here, these are stimulation electrodes. So these are recording electrodes here. We're recording muscle potential. And these are stimulation electrodes. Now, in hemifacial spasm, there is a electrophysiological phenomenon known as the abnormal muscle recording that only happens in patients that have hemifacial spasm. and hemifacial spasm. And the reason why this is it's kind of this weird backfiring to the motor nucleus. So what happens is we stimulate the nerve here in the face. This is the zygomatic branch of the nerve, and we get a muscle response from this muscle here. But what happens is impulses go back to the brainstem, to the cranial nerve nuclei of 7, and then impulses get sent back to a different branch altogether and it's a later response called an abnormal muscle recording or a late muscle recording, and it's abnormal, and it only happens in patients with hemifacial spasm. As soon as the hemifacial spasm is removed, the offending vessel is removed from the nerve, this goes away. This is one of the only tests that I do where I can tell a surgeon they have cured the patient in real time. This is what it looks like on our screen. This is us just starting to get the response here. We're increasing our intensity, and what you'll see here in a second is you'll see the responses come in, and there it is. So, and I'm going to clean it up in a second so you can see it, but these are the muscle responses here. And then here we have these abnormal responses coming in later. And I'll show you, this is a little easier to see here. This is the motor response here, and this is that abnormal response. And the idea is that if this goes away, I can tell the surgeon they have cured the patient. So here's trend over time. Here are the motor responses here. Here's that abnormal muscle recording. Now, as soon as they open the dura, we lost the abnormal muscle recording. And the reason why that happens is everything kind of falls away as there's a release of cerebrospinal fluid. However, the response did come back with an increased intensity, which shows us that the offending vessel was still there. As soon as they found the offending vessel, they took it off. And as you can see, these abnormal muscle recordings go away completely. And with that, I was able to tell the surgeon, this patient is cured. They will wake up completely with no hemifacial spasm at all, which is what happened. Again, this is showing the same thing. Direct motor responses here, and then the abnormal muscle recording going away. You can see it here. Here it is. And again, if you know, all of you guys in the audience, you don't have hemifacial spasm. If you did this test, you would look like this, because that's what a normal person should look like. If you have a hemifacial spasm, you would get this. And this, again, is indicative of curing that patient. And this is just showing you what kind of that sponge material looks like. They put it between the vessel and the nerve to keep that nerve from pulsing on the face. Okay, I think we're kind of winding down here. This is, I hope I'm doing okay on time, so I never really timed this lecture. But this was an interesting case that I don't know, 15 maybe years ago. And this was an extension of a fusion. For us, not really a big deal case in the sense of, from a monitoring standpoint, it's pretty straightforward. What the issue here is the patient's underlying comorbidities. And again, all of these symptoms are red flags to me and my ability to get nervous system information from the patient. But I want to point out that this patient's motor system completely intact. This patient walked in, 73-year-old female, walked in, has a slew of medical issues, has some sensory problems, you know, but ultimately motor function wise, they are intact. So when we look at our pre-positioned baseline, so what we do is we're going to put the patient prone for surgery, but we want to get baselines while they're supine to make sure everything is stable before we turn them over. And what you're seeing here is just noise. There's nothing here. There's no responses from our sensory tests. These are sensory tests. And it kind of made sense clinically. This patient has sensory problems, has a slew of underlying medical problems. So here I'm not so concerned. This doesn't necessarily preclude me from moving on to the procedure or telling the surgeon we have issues. Now we run the motor potentials though in that same supine position. And what we have is our upper extremity. Remember, this is a thoracic fusion, so it's the lower thoracic, T12, the lower thoracic area. So my hand muscle is a control. If I have a hand muscle, I know that the system itself is working. So what you see here, it's again top to bottom, trend over time in the case. I have no motor potentials from the lower extremities here. So this didn't make sense to us. So we started questioning things. We started saying, well, there's something going on here. What's going on with this patient? And we decided to start to wake the patient up because this just didn't make sense. and we wanted to make sure they were able to move everything. Remember, they're lying down on their stretcher base under anesthesia. So what we did was we decided to move them into a more seated position. And as we move them into a seated position, you can see that we start to get a response here from the motor potential. And then we laid them back in that supine where we extended their back again, and we lost the signal again, sat them up, and the responses came back. And we go, wait a second. There's something happening to this patient's spinal cord. This is very, very specific. Every time we extend, the signals go away. When we bring them, we sit them up, the responses come back. So we need to see what's going on with this patient. This is the left side. This is the right side. It's the same information, just a little more affected from the left side. The issue here is we didn't have an updated MRI for the patient because, like I said, the surgery was done probably 15 or so years ago. So they had a spinal cord stimulator in place. And because of that, this was prior to the surgeons putting in MRI compatible stimulators. So the patient couldn't get an updated MRI at the time. So we didn't know what was going on in this patient's spinal cord. So the patient, we had to get that spinal cord stimulator out and do get an MRI done to see, because something's obviously going on in this patient's spine. Because again, the sensory test, we can say, okay, we're not getting sensory because the patient's underlying comorbidities, but why are we not getting motors when they walked in? So we woke the patient up. We decided to stage this. We needed to get that spinal cord stimulator out. And we actually asked the patient when they woke up, when you sleep, how do you sleep? And they said, well, I always sleep propped up because I can't extend my back. Every time I extend my back, I get a ton of pain. I can't move. So we knew this is exactly what was happening intraoperatively. We're seeing it, under anesthesia, electrophysiologically. And basically this patient lived in kyphosis. They lived bent over. So they never extended themselves. Every time they did, they would have an issue. So the surgeon had to get that spinal cord stimulator out. It was too dangerous to do it asleep. So he went in and actually did an awake procedure, positioned the patient, maintaining kyphosis, positioned the patient laterally, and took this spinal cord stimulator out. And we're able to get it out uneventfully, thankfully. And then we were able to get an MRI for the patient. And then when we get the MRI, we see this terrible buckling that's occurring. So every time the patient extends, so this is that kyphosis. Every time we extended them, the T12 would buckle into the spinal cord and cause a loss of signals down the spinal cord, basically paralyzing the patient. So now that we knew this, we knew that we could position the patient more appropriately in surgery. So what we did was we came back a few weeks later and had an uneventful surgery. Had beautiful signals, both sensory and motor. So even those underlying comorbidities that we said, oh, we're not getting sensory potentials, it really had to do with the loss of conduction every time we extended that patient. We were able to bring them and keep them in a much more stable position in the next procedure, and ended up with this excellent correction, and patient ended up doing great. So I just want to thank everyone. I hope I didn't rush through that or speak too quickly for anybody, but feel free to send me any questions, or again, follow me on my socials. And I guess if there's time for questions, we can always open it up. And thank you again, Brain Turns, for allowing me to give this talk.
Thank you so much, Dr. Silverstein. Your talk was incredibly interesting. Brain Turns, if we could say thank you to Dr. Silverstein for taking the time to speak with us today. Unfortunately, I don't think that we have time for questions because our next speaker, Dr. Sean Rogers, is already here. But again, thank you, Dr. Silverstein. We greatly enjoyed your presentation, and thank you again for taking the time to talk to us.
Thanks, everyone.